Hello, everybody. My name is Sean Hennessy, and I work at the University of Pennsylvania. Today, we have an exciting and thought-provoking symposium entitled Drug-Drug Interaction Research, Twice the Fun or More. This symposium was organized by members of ISPE's new special interest group on drug-drug interactions, which we hope you'll join. I'm going to briefly introduce all of the speakers up front. If you have questions, please enter them into the question box, and we will address as many of them as we can following everyone's presentation. Anton Pottegard from the University of Southern Denmark will introduce the topic of drug-drug interactions and describe how the current state of evidence is insufficient to guide treatment decisions. Meija Zhao from Johnson & Johnson will then review the challenges inherent in using healthcare data to study the health effects of drug-drug interactions. Charlie Leonard from the University of Pennsylvania will then describe how these challenges can be met using the cohort design as an example. Kate Bykoff from Brigham and Women's Hospital and Harvard Medical School will then present how real-world data can be harnessed to screen for potential drug-drug interactions using self-controlled designs. Finally, I'll talk about efforts to disseminate and improve the impact of pharmacoepidemiology research on the health effects of drug-drug interactions. Anton, please lead us off.
Thank you, and thank you for the presentation. I hope you can see my screen. Is that the case? Wonderful. So I'll get out of this interface and into my presentation. So my name is Anton. I'm a professor of pharmacoepi at the University of Southern Denmark, and I've been charged with sort of getting us started into the field of drug-drug interactions. And as you will realize, I will approach this with a sort of a grumpy old man attitude, but I'll get back to that. First, of course, the mandatory conflicts of interests and monetary ones. I work with different pharma companies, nothing related to drug-drug interaction and nothing of relevance of the presentation today. I have another conflict of interest or disclaimer, which is more important, I think. I need to disclose upfront that I am, at my core, a DDI skeptic. I honestly believe that the majority of drug-drug interactions that we talk about in sort of a daily routine clinical setting are of lesser or no clinical relevance whatsoever. So when Kate sort of asked me to present or get us started on the field of interactions, it's sort of like asking the wolf to look after the sheep. My initial somewhat provocative question is drug-drug interactions really a thing? For me, it all started with this classical case. The majority of us, in particular pharmacists, will know this interaction. We know from our basic chemistry understanding that it's something with calcium ions chelating the iron ions so that we will end up having this bound and not absorbed into in the guts. And ultimately, if you take your iron supplements together with calcium or milk or food with a high calcium content, you will end up having or getting too little iron. This is a classical one. We all understand it, in particular because it's such an easy one to understand since it sort of resonates with our basic chemistry understanding. I had a senior tell me once that I shouldn't really pay attention to this DDI. It's not important, he said. This is a picture of me when he said it. This is from my early clinical years. But of course, as we all do, or at least did early in our careers, we actually went back to the literature to test whether those claims were true. I found this review on absorption of iron in the presence of calcium. We have some studies, a single meal study that says something like 70% of the iron is bound by calcium if ingested simultaneously. That's the worst case scenario, and probably it's more average in single meal studies about 50%. In repeated meal studies, it's probably about 30%, but who's counting? The main thing, regardless of whether it's 30, 50, or 70%, is that when we actually give iron supplements, we give a vast surplus of iron. And considering how much we sort of present in the intestine and what is needed to cover the sort of the basic need for iron, even if you're iron deficient, it doesn't really matter whether 30 or 50% of it is bound by calcium. In particular, because if you have low iron, the body, of course, upregulates how you absorb iron ultimately. So this ended up being a not so important interaction, which is actually important news seeing as we, for instance, have quite many pregnant women trying to wrap their schedule around taking their calcium supplements in the morning, iron for lunch, calcium supplements for the evening, and iron supplements before going to bed to avoid this overall completely nonsensical drug-drug interaction. So this is a picture of me just after that. This is a problem, right? Because we've been taught something, but it doesn't necessarily sort of hold up to be true ultimately. This is another example. This is augmented foods. This is an example, not to go into this particular case, but to take a specific quote to discuss. In this paper, they say, as shown, the list of affected drugs is quite impressive. Of note, only drugs with moderate to major interactions were extracted. The list is much more extensive, when minor interactions are also included. And I was, oh, wonderful, I can go by this. If the calcium iron thing isn't important, I probably just have to restrict myself to considering moderate or major interactions. That's probably a solution to my problem. Then I read this paper. They, in this paper, have abstracted 400 major, not moderate, not minor, but major interactions. 400 major interactions from 4 different respected data sources: micrometrics, evaluation, drug interaction facts, and drug interactions analysis and management. These 4 sources reported 400 major interactions. However, only 100 of them was mentioned in more than one of these 4 sources, and only a very small fraction of them was mentioned in all 4. So that gave me a new problem, that even if I restricted myself to major interactions, there are still quite many of them to take care of, and the expert sources don't quite agree what is really a major problem. This is a problem, at least not a DDI problem. It's a problem to me because I'm now in an information overload scenario. If I, as a young clinician, need to take care of or handle or consider all these drug-drug interactions, I will be in a situation which is like drinking from a fire hose. I have no way of memorizing or learning or sorting all of this information in a meaningful way. And a potential unimportant DDI, for instance, calcium iron, might end up sort of reserving space in my brain from something that was actually clinically relevant, that is now not sort of room for when I'm trying to remember all these. A final piece of evidence is that this is typically what you see arguing, well, we need to take care of DDIs, or at least consider DDIs because they are so prevalent. This is typically used as an argument in favor of DDIs being a problem, but I really like such arguments because they support me in my argument that DDIs are not a major clinical problem. This is from a paper by Lars Bjerrum outlining the proportion of patients using different drugs and the proportion of them apparently experiencing some kind of drug-drug interaction by cross-referencing drug DDI info with drug fills. And as you see here, for instance, the diuretics, the top one of the diuretic users, 5% apparently have a major interaction going on. For the anticoagulant user, we are up to about 20%. Overall, these are very large numbers, in particular if they are summarized across all the different categories. So this might be an argument that DDIs are very common, highly prevalent. To me, this is an piece of evidence suggesting that DDI literature is off, seeing as if this was really the case, we would all immediately meet a DDI patient walking into an emergency department or hospital ward, but we do not. It's not a common scenario to see people admitted due to DDIs to this extent. So this mainly argues to me that there's probably a problem with the classification of DDIs and the literature supporting our use of these sources of information. So this is, of course, not exactly ideal. So we will think, okay, how to approach this from a different perspective, what to do from here based on, if not this realization, at least this understanding of the current state of practice. We devised 4 different ideas of rules of thumb. So when we should actually act upon a potential DDI and when we should not. So we present 4 different sort of scenarios or criteria. First off, one drug needs to have a narrow therapeutic interval. Secondly, that drug needs to have respected and recognized drastic consequences of either over or under treatment. It should be hepatically eliminated, preferably by one enzyme only, which increases the likelihood that a DDI blocking that will actually lead to marked changes. And then we sort of prefer there to be consensus between different sources. It needs to be something that is indexed more than one place. Later on, we've revised this. So as you can see, the third one is now blinking, changing into the drug needs to be transported or eliminated by one enzyme. It's the same thing as monoenzymatic hepatic elimination, but broadened in the sense that if it's, for instance, absorbed via PGP or other specific enzymes blocking, that can also lead to drastic effects. So it's a matter of whether one enzyme is really key to this. We suggest that we should have at least 2 or 3 of these met before we sort of take a potential DDI seriously. Consider the iron supplements and calcium here, no narrow therapeutic interval, no consequences of over and under treatment, certainly not highly dependent on one protein, and certainly no consensus between data sources. Using these rules, we would disregard it in a clinical setting. Consider instead oral anticoagulants, warfarin, narrow therapeutic interval, oh yes, drastic consequences of over and under treatment, absolutely, highly dependent on one or few proteins in terms of elimination, and certainly consensus between sources. So this tool seemingly identifies at least some drugs that are drug classes that we should pay attention to. The list is fairly short, however. I'm sure you can come up with examples of other drug classes that meets these criteria. This is not meant to be exhaustive, but just a few examples. There are drug classes where this is relevant. So I'm not saying all DDIs are irrelevant, but I think we should actually focus on some select classes that, for instance, meet the criteria of drastic effects of over and under treatment. Once we have narrowed it, now I'm back in my clinical setting, I need some sort of guidance as to how to. And the next suggestion would be to then go into the literature when you have something that you need to evaluate. This is from a Danish sort of index of medications used for warfarin, and this lists that you should pay attention once you treat warfarin users with dicloxacillin and rifampicin. And I've used this example for teaching purposes for quite many years. You, of course, go back to these overall criteria and you realize, yeah, well, warfarin is certainly a drug where you could expect actual problems. So you need to go into the different sources and look at the literature supporting the potential interaction with dicloxacillin and rifampicin. And you can use whatever DDI database you would like. I use, in this case, a Danish one called Interaktionsdatabase and the database of interactions. This highlights very clearly that the rifampicin issue is really an issue. It's a 3-fold increase in clearance. So we really expect there to be a marked effect. And this is also what is classified as a pronounced clinical important and well-documented level of documentation. On the other hand, dicloxacillin said, consider monitoring INR values during concomitant treatment. We have one prospective study seeing a modest drop in INR or in prothrombin time, but a proxy. And we have 2 case reports, clinical importance, possible level of documentation, poor. I used to use this as an example of saying, well, so if you restrict it as suggested, you should go to the original literature to evaluate, or a condensed version of the original literature to evaluate why and how you should handle a specific DDI. And in this case, I end up with, okay, got it. Rifampicin is a problem, dicloxacillin is probably not a problem. Ironically, after having used this as a teaching example for several years, I ended up being the one to report the interaction between dicloxacillin and warfarin. We reported this in JAMA quite many years ago, seeing a marked drop in INR values, and we have fairly recently published in CPT a paper suggesting that there is an almost doubling of the hazard of experiencing a stroke in the sort of interval after initiating dicloxacillin treatment due to this sort of lessening of warfarin effect. And that sort of gets me back to this particular state of mind, because I have argued that you should be critical, and you need to address the literature, but this is not a perfect solution. And that, I think, I hope is the proper sort of starting point for the presentations we're going to hear, in that while we need to be very critical and focused in how we address this, we certainly need to provide more evidence in the relevant areas. And I will sort of summarize my points like this. I do believe most interactions as currently classified can be considered clinically irrelevant. We need to focus our efforts on high-risk therapies, I've listed some examples, but it's certainly not exhaustive. We need to reconstruct DDI databases to better support clinicians, and that I think speaks very directly to Sean's talk towards the end. And finally, as any epidemiologist and scientist ever, I need to end with that more studies are needed. But I do think more studies are needed. While a lot of the data is not relevant, we are not in a position to say we have already got it covered. We need better and more studies on those high-risk situations. I've included this as for the recording, so you have my contact information. And thank you. And I'm really looking forward to seeing all the other presentations, hopefully going from here. Thank you.
Thank you, Anton. Let me know when you can see my screen.
We can see it.
So, thank
Can you put it into presenter mode though, May?
Oh, I am in a presenter mode, so you are not seeing the.
Yes, we're seeing the wrong screen. We're seeing the screen, but the wrong one.
Oh.
May, if you go to display settings at the top, you can switch which screen it's on.
At the top, sorry, where is it?
Pull your presentation back up, pull the PowerPoint back up.
Sure. Yep.
And then at the top, you should see show taskbar display settings. It's the second one over.
I'm sorry, which, I don't, if I go to the top of my.
Nope, if I'm actually on the PowerPoint presentation, when you're looking at the speaker notes, you should see display settings at the top. There you go, click on that, and then swap presenter. There you go.
Okay, thank you.
No problem.
Sorry about that. Thank you. So my name is Meijia Zhou. I'm currently a manager in the medical device epidemiology and real world data sciences group at Johnson & Johnson. I'm happy to present today on the major challenges of conducting observational DDI studies in electronic healthcare data. Here's my disclosure. As mentioned, I'm currently an employee of Johnson & Johnson, and what I present today only reflects my own opinion. So an overview of my presentation. So I'm going to cover the study design considerations, control groups, validity of outcomes, as well initiation order of the object and precedent drugs, and time course of DDI. The topics I cover today are more describing details in this paper published in 2016 in the Clinical Pharmacology and Therapeutics titled Pharmacoepidemiologics Method for Studying the Health Effects of DDIs, which Sean and Charlie co-authored. So first, to introduce the terminology of the DDI research. In the DDI research, we define the object drug as a effective drug, where the precedent drug, in a considered two-drug DDI, we call the effective drug to be the object drug, and then the affecting drug would be called the precedent drug. And thinking of one of the example here, if we are looking at we're interested in studying the concomitant use, the effect of concomitant use of warfarin plus amiodarone on the risk of bleeding. Warfarin in this case would be the object drug, and precedent drug in this case would be the amiodarone. In terms of selecting the study design, we would one of the basic design one would consider would be the cohort design, in which we compare the frequency of outcomes in different exposure groups. So we might want to start with, so there could be 4 groups of interest. One would be the object exposed group, and the first one would be patients who are exposed to both the object and precedent drug, and the second group would be the patients both are exposed to the object drug but unexposed to the precedent drug, and patients are unexposed to the object drug but exposed to the precedent drug, or patients who are exposed to neither of the drug. If we define DDI as a departure from the multiplicity, we can conclude there is a DDI if we can reject the non-hypothesis that the incidence rate comparing the both exposed group to be both exposed group versus the neither exposed group to be different from the incidence rate comparing the object exposed group versus neither group multiplied by the incidence comparing the precipitin exposed group versus neither exposed group. However, one of the key assumptions underlying this simplistic design would be there's no, it assumes there's no among person confounding by measured confounding by indication by object and precipitin drug, which is impossible for most of the drug pairs. So a better approach would be if we nested within the person time exposed to the object drug. The first design one we can consider would be to compare the precipitin exposed persons are precipitin exposed versus precipitin unexposed, which comes with the key assumption that there's no confounding by indication by the precipitin drugs. And it also assumes that this precipitin drug alone has no intrinsic effect on the outcomes. An alternative design would be we could also compare the person times where patients are precipitin exposed versus the time when the patients are exposed to a controlled precipitin drug. Compared to the design on top, if we're able to select a valid controlled precipitin drug, this design would help to reduce the susceptibility to confounding by indication for the precipitin drug. However, this does come with the assumption that there is no interaction between the object and precipitin control. The design, which is nested within the person time exposed to the object drugs, can not just apply to a cohort framework, it can also be applied to a case-controlled framework, which compared to the cohort framework would be more computationally efficient. However, it does introduce the challenges that it could, in terms of defining the timing to measure potential confounders. If we adjust it for confounders affected by exposure, bias could be introduced into the analysis. One other design could be used would be the self-control designs, which could be a self-control case series or a case crossover design. Both are case-only design, which means we'll only include individuals who experience one or more outcomes. Each person would be, in this case, each person would serve as his or her own control, such that this design intrinsically controlled for any fixed covariance. Since only cases are included in this analysis, so this design is also computationally efficient. But for it to be feasible, it does require there to be within-person variability in terms of the exposure time to the precipitin drugs. So only patients with both precipitin exposed versus unexposed time would be able to contribute any information to the analysis. Talking about the control groups, we could use different control groups in the design when studying a DDI. The first would be we could consider to use the negative control precipitin drugs, as we have covered earlier, if we're selecting a control precipitin drug, which would help to reduce the susceptibility to the confounding by indication for the precipitin drug. So a negative control precipitin drug would be a drug that used for a similar indication as a precipitin drug of interest and not believed to interact pharmacologically with the object drug. And we could also consider to use a negative control object drug, which would be a drug used for a similar indication as the object drug of interest, but not believed to interact pharmacologically with the precipitin drug. And this, by using the negative control object drug, it will help us to distinguish from a real DDI versus the intrinsic effect of the precipitin drug on the outcomes. Lastly, we could also include a positive control precipitin drug, in which case we would select a known DDI pair in order to demonstrate the ability of which would help to demonstrate the ability for our assay to be able to reproduce a well-established DDI. And just so DDIs often can lead to increase or diminish pharmacological effects of the object drugs, just as all the pharmacoepidemiologic studies, we would want to make sure we have a validated outcome to minimize the potential misclassification. So it is better if we can select a previously validated claim-based algorithms with known validity and performance. Another consideration would be thinking about the initiation order of the object and precipitant drugs. So on the slide I presented, here are 3 different scenarios when the patient could initiate this concomitant use. So in the first scenario, the patient, in this example here, the patient is already on amiodarone, and then later on the patient initiated the warfarin drug. In this case, we would call it a object trigger concomitancy. And the second scenario would be the reverse. The patient was already on warfarin and then initiated amiodarone. In this case, it would be called a precipitant trigger concomitancy. And lastly, the third scenario, it could be the patients initiated both drugs at the same time, which could be called a combination trigger concomitancy. So when thinking of, so we could do a stratified analysis by groups of the different differentiation orders for the orders of initiation, and this kind of initiation order would be the most relevant for the dose titration object drugs, because the likelihood of the outcome in that case may be limited to the precipitant trigger groups. For example, thinking about the example of warfarin in a prior study, when we look at the drug-drug interactions involving warfarin on the INR, we did require the patients to be stable on warfarin before they initiate amiodarone. Next would be the time course of DDI. So just similar to the rationale for the widely used new user design in any pharmacoepidemiologic studies, we will want to study the incident concomitancy in DDI studies. So in most cases, for most of the drug, we would expect the risk to be exposed, the risk to peak shortly after the patient's exposed to the concomitancy, and then it will decline over time. So the potential mechanism for this pattern would be depletion of susceptible biological adaptation to the object drug or biological adaptation to the precipitant drug, or the clinician may see the initial toxic effect of the concomitant use and start to reduce the dose of the drugs. As we see, if the DDI follows this kind of pattern, we see there is a transient increase in risk at the early phases. However, if we are studying the average risk over the follow-up time, it may not be increased. So in this scenario, we would want to study the duration response in pre-specified time window for us to be able to describe this kind of time course. Thank you very much. That's the end of my presentation.
All right, thank you, May and Anton. I'm hoping folks can hear me and see my screen.
Yes, to both.
All right, thank you, Sean. All right, although all right, well, thank you for setting the table, Anton and May, and it's my pleasure. I'm Charlie Leonard from the University of Pennsylvania. It's my pleasure to talk about using a cohort design to generate real-world evidence on an anti-diabetes drug interaction, in particular, answering the clinical question, what are the effects of different anti-hyperlipidemic drugs on hypoglycemia rates in sulfonylurea users? right, and so here are my support and disclosures. The work herein is funded by the National Institutes of Health. So I'd like to start with this clinical case. So this is a case report that was published back in 1991. It describes a 53-year-old woman with type 2 diabetes. She'd been taking the sulfonylurea glyburide for 9 months with good control. She then initiated gemfibrozil, a fibrate for her high triglycerides, and she was then seen in clinic 3 weeks later. 3 weeks later, her blood glucose was low, and the patient and her husband had stated she'd actually been having attacks of hypoglycemia since starting gemfibrozil therapy, and had even fallen on 2 occasions. So the clinician advised her to reduce her dose of the sulfonylurea from 5 to 1.25 milligrams a day. And in this case report, summarized that when gemfibrozil is given to a patient receiving a sulfonylurea, that he or she should be closely watched for loss of glucose control. So why do I start with this clinical example? Well, the outcome, as Anton alluded to, is pretty critically important. It's very concerning. Hypoglycemia is an expected and common side effect in folks treated for type 2 diabetes. 1 in 5 sulfonylurea users will have an event in the first 6 months, and it has significant consequences. It can lead to falls. It's been associated with major adverse cardiovascular events and death. And in the US at least, drug-induced hypoglycemia is one of 3 high priority targets to reduce adverse drug events. Furthermore, co-exposure between these 2 drug classes is relatively common. Sulfonylureas are commonly used worldwide. In the US, they're still the #1 add-on to metformin, despite all the new therapies that are available. And 1 in 4 individuals with diabetes has a dyslipidemia. And these folks tend to have an atherogenic triad of high triglycerides, low HDL, and high LDL, and leads them to therapy on either a statin or a fibrate drug. And so what is the putative mechanism that might underlie this interaction? So here you can see on the left-hand side 3 US available sulfonylureas, glyburide, glipizide, and glimepiride. They're metabolized hepatically by the cytochrome P450 system, predominantly 3A and 2C9, to mostly inactive metabolites. Now, some statins and fibrates, but not others, could potentially inhibit the hepatic metabolism of these sulfonylureas, leading to increased concentrations of those drugs being around, further lowering blood glucose and placing patients at risk for hypoglycemia. And as May just alluded to in her last talk, in the setting of this potential pharmacokinetic interaction, we would consider the sulfonylureas as object drugs, the affected drug, whereas the statins and fibrates as precipitants, the affecting drug. Now, our hypothesis in the series of cohort studies was that the rate of serious hypoglycemia in concomitant users will actually increase with the strength of the given antihyperlipidemic's ability to inhibit CYP2C9 and or 3A4. And we were really intrigued by this because the current recommendation, and I'm just picking on Micromedics here, who labels this a moderate drug interaction, the current recommendation is based on a single case report, that case report that I started my talk with. It was published in 1991. So again, our objective was to examine the putative drug interaction between sulfonylureas and antihyperlipidemics on an outcome of serious hypoglycemia. As I alluded to, we conducted a series of retrospective cohort studies. Our setting was the United States Medicaid program, primarily for economically disadvantaged individuals, from 1999 through 2009. Our participants under study were adult new concomitant users, and this new use definition carries some implications that I'll talk about a little bit later. But everybody under study was on one of the 3 sulfonylurea drugs as an object and one of a handful of antihyperlipidemic drugs as the precipitants. And to help contextualize our findings, we utilized as a negative control object drug metformin. And the reason we did this was to help us to give us some information as to whether the precipitants in and of themselves had some intrinsic effect on hypoglycemia. And the reason we could do that is because metformin in and of itself has a very low to no rate of hypoglycemia. And we wouldn't expect a pharmacokinetic interaction between metformin and the precipitants under study because metformin is renally metabolized, not hepatically metabolized. Furthermore, to minimize confounding by indication for the precipitant drug, each of our comparisons was compared to a negative control precipitant of pravastatin. And the reason we selected that is because it has negligible CYP inhibition, therefore you wouldn't expect a pharmacokinetic interaction, and in and of itself has minimal effect on plasma glucose. So again, everybody under study was co-exposed, and our exposure of interest was actually which antihyperlipidemic drug you were co-exposed to. Our outcome was a validated diagnosis-based algorithm for a serious hypoglycemia within the first 180 days of concomitant therapy. And functionally, this was hospital presentation for a hypoglycemic event, whether it be emergency department or inpatient admission. We addressed confounding by adjusting for multinomial high dimensional propensity scores, and our time to event analysis utilized Cox proportional hazards regression. So quantitatively, we calculated hazard ratios, which you can interpret as the rate of hypoglycemia in people taking both the object and precipitant drug together, divided by the rate in people taking the object drug with the negative control precipitant. And this is where every comparison was made to someone taking the object with pravastatin. Further, we qualitatively compared the hazard ratio for the object drugs of interest, that is the sulfonylureas, versus hazard ratios that we calculated using metformin as a negative control object drug. So may define these concepts, but I just wanted to go through them again because I think they're critical, that folks could have entered our study in three main ways. One, they could have had precipitant triggered cohort entry. That is, they entered upon concomitant use because the precipitant drug was initiated. So you can see here that this individual or set of individuals that entered this way were previously on a sulfonylurea, then initiated the antihyperlipidemic. That's when we started following them until they were no longer on concomitant therapy. And why is this important is you can think about what the underlying outcome rate might be in the set of individuals that enter the cohort this way, and the time period at which we're actually observing. So you can see here on the bottom panel that this individual might, or set of individuals might have a transient increase in the probability or rates of hypoglycemia prior to cohort entry, given by the initiation of the sulfonylurea, which may decline over time, whether it be due to adaptation or depletion of susceptibles, but then maybe another transient bump if the initiation of the antihyperlipidemic inhibits the hepatic metabolism of that sulfonylurea, and then the rate goes down over time. Now, for those entering the cohort because of object-triggered cohort entry, that is, they were previously on an antihyperlipidemic and then start a sulfonylurea or the metformin, you could see potentially slightly a different pattern, just as an example. Whereas there'd be little to no hypoglycemia before initiation of the anti-diabetes drug, then a transient increase, a rapid increase that could potentially be attenuated if the antihyperlipidemic on board is a metabolic inhibitor, and you could potentially see the rate go down over time. Interestingly, and we wouldn't observe in this current cohort design the way constructed, is that if you discontinue the antihyperlipidemic, especially if it inhibits the metabolism of the sulfonylurea, that theoretically upon discontinuation, you could get a functional increase in the sulfonylurea dose because the metabolic inhibitor is no longer on board. So it's possible that these types of individuals could experience a bump of hypoglycemia after discontinuation of the precipitant drug. That same pattern would be true for synchrony-triggered cohort entry. Traditionally, this has been called combination-triggered, as May pointed out in her last talk. So here are the findings from our series of cohort studies, and let me orient you to this. So again, this is looking at serious hypoglycemia within the first 180 days of concomitant use. Along the y-axis are the hazard ratios. And each of these individual panels along the x-axis are our object drugs of interest, the sulfonylureas, glyburide, glipizide, and glimepiride, and our negative control object, metformin. Each of these point estimates within each group is exposure to a different antihyperlipidemic drug, each compared to pravastatin as our negative control precipitant. So you can see in the far left-hand panel, atorvastatin had a hazard ratio of 1, lovastatin 1, rosuvastatin 0.9. Now, the shapes for these point estimates that are red indicate that prior data exist that suggest that that individual antihyperlipidemic actually inhibits the hepatic metabolism of the anti-diabetes drug in the given cohort study. So you might suspect that if we were demonstrating a pharmacokinetic interaction, that all of these red point estimates would be elevated above 1, and that's absolutely not what we're seeing here. But what you might notice is that for the fibrate drugs, that is fenofibrate and gemfibrozil, regardless of whether or not they inhibit the hepatic metabolism of the sulfonylurea, you can see elevated hazard ratios that are circled here. And in particular, for metformin monotherapy, our negative control object drug, a drug that in and of itself causes very little hypoglycemia, which leads to these very wide confidence intervals, few events, you could see a suggestion, even for fenofibrate, that the initiation of that fibrate drug in and of itself is potentially related to hypoglycemia. In an exploratory analysis, we also looked at this, the time course by days since concomitant use, and just simply demonstrating here as one example for the sulfonylureas and fenofibrate, that you can see some delayed effects where the hazard ratios actually peak in the 2nd and 3rd and 4th months of therapy rather than right away. So our series of cohort studies support a pharmacodynamic interaction of sulfonylureas and fibrates, driven by these fibrate findings that I just discussed, in addition to the fact that we saw null associations for sulfonylureas with CYP-inhibiting statins compared to the negative control precipin and pravastatin. Further, our suggestive positive finding for our negative control object, that is metformin with fibrates, helps lead to the same conclusion. Finally, there is a biologic basis here. It's pretty well demonstrated that fibrates have PPAR alpha pleiotropic effects, which can impact glucose, and there could be potential off-target effects at PPAR gamma, which some folks might recognize as the same site of action as anti-diabetic thiazolidinediones. So there is some plausibility here that fibrates could lower glucose in and of themselves. So in conclusion, the take-homes are that we demonstrated a likely pharmacodynamic interaction between sulfonylureas and fibrates. Our inclusion of a negative control precipitant drug helped to minimize confounding by indication in this cohort design. Our inclusion of a negative control object drug, that is metformin, helped us elucidate the potential intrinsic effects of fibrates on hypoglycemia. And therefore, we're confident that this really helped the DDI evidence base advance beyond the prior case report, which has been reported as the only evidence for this potential interaction. So I'll stop there. Thank you.
Good afternoon. I'm not sure you guys can see my screen.
Yes, we can.
Yes, we can.
You can, I cannot. That's the problem. Okay, I think I'm good. Let me just get rid of the questions. All right, so good afternoon, everybody, and good evening in some places, hopefully not too late into the night. I'm Kate Bykoff, and I'm going to be building up on previous presentations and giving you a brief overview of drug-drug interaction screenings, particularly focusing on self-control designs for the reasons I will explain later. Here are my disclosures. Some of the work that I might be presenting was funded through Lilly Research Award. It was purely methodological work, had nothing to do with any of the drugs Lilly's manufacturing, and I'm also a consultant to Alosa Health for work unrelated to DDIs. So I'm going to start with a brief overview with a question, actually, why we're even interested in running DDI screening or data mining actually exercises. And this is very related to the idea that Anton presented in his presentation, that the current evidence base is pretty much not satisfactory for us. most of the information we get from DDIs comes from either preclinical or phase 1 clinical trials. They look at healthy volunteers, evaluating kind of like how the blood levels change. And then as a consequence of this, investigation, we have two issues. First of all, some interactions could be missing because they're operating through untested mechanisms. For example, 15 years ago, we were not talking about PGP inhibitors. Now it's a major thing. And also, and this is again related to what Anton said, we have thousands and thousands of potential interactions based on pharmacological data. And most of these interactions probably have no clinical effect, but we don't know which ones. And even though sometimes, like Anton presented, we have some ideas, maybe it's like narrow therapeutic index drugs, maybe it's some kind of like drastic side effect, but the reality is we don't know in most cases which interaction will or will not lead to clinical harm in patients. So I still believe that cohort studies is the best way to evaluate a drug-drug interaction, but the reality is if all of us, for the rest of our careers, will be running cohort studies, we won't be able to look at all possible drug interactions out there, even if we'll limit ourselves to those that have pharmacological evidence, not even talking about those we don't know about. So wouldn't it be nice if we could take all this huge amount of data, observational data that we have, and screen or do some sort of like data mining, exploratory analysis to zero down at the end on a few particular drug-drug interactions that we think might lead to clinical harm in patients. And then we run the hypothesis testing exercises for those interactions. And this paradigm still works within kind of like a pre-specified object drug and outcome. For example, we're interested in warfarin and bleeding, or we're interested in simvastatin and rhabdomyolysis. And then within this pre-specified framework, let's screen all co-prescribed drugs that patients encountered and see what happens. So over the past 5 to 10 years, there's been quite a lot of work done in this area to kind of like design DDI screening methods, and I'm presenting some of that. As a disclaimer, we are not the only ones who are doing DDI screening exercises. So also data scientists and computer scientists have done work in this area, but since this is a pharmacoepi symposium and I'm a pharmacoepidemiologist, I'm going to be focusing on work that has been done in pharmacoepidemiology space. So let's take a step, like a kind of like a step back, a broad overview. What are the main components of a screening algorithm? So first of all, you need some sort of like study design that will estimate associations and hopefully will address bias. And then you will need some way to rank or prioritize your estimates or your drugs while addressing signals due to chance. A very common study design for DDI screen algorithms is self-control design. By no means this is the only possible way to do a screening. You can actually implement any design you want. You can do a cohort study, a case control, or some other methods. But so far, we primarily focus on self-control designs. So why self-control designs? And May kind of alluded to that in her presentation. These are very convenient designs for screening for major reason that the comparisons are done within individuals with outcomes. So one advantage of that is that you don't need all the data that you have. You can only focus on patients who have outcomes, and this is already nice, even though in our age we don't have to worry about programs running for days and days, but still. But the major advantage is that if you're comparing people to themselves, you're controlling by design for all potential confounders that are stable over the observation period or the comparison period. And this period can be quite short, can be 3 months, can be 6 months, sometimes even shorter. So it's not only something that's really stable like sex or genotype, but also like chronic conditions or BMI or socioeconomic status. And very often we don't even have this information in claims data, for example. So it's nice to be able to control for it by design. In DDI screening exercises, we take it a step further and we control for confounding by indication for the object drug by nesting all our analysis within object drug exposed person time. And as May alluded, object drug, very often the DDI, the outcome of a DDI is an altered effect of the object drug. So confounding by indication for the object drug is the major source of confounding in DDI analysis, including screening. And here you have an example. I'm presenting here 2 major self-control designs that have been used for DDI screening exercises, case crossover and the self-control case series. And the idea is the same, and you can see in yellow that in both designs, we do analysis within person time exposed to the object drug. So object drug exposure becomes a stable characteristics, and therefore there is no confounding if it's not changing. And both of these designs have been tested before, and they have shown that they can detect known DDIs without producing too many false positives. And both of these designs also share the assumption, the major assumption that is common to all self-control designs, that there is no within-person confounding. Do we have to worry about within-person confounding? And the answer is absolutely yes, because we have precipitant drugs. So in both of these designs, you will be comparing, in the case crossover, you will be comparing exposure to the precipitant during the hazard window to the exposure to the precipitant in the referent window. In the self-control case series, you will be comparing outcome incidence during precipitant exposed person time to outcome incidence during precipitant unexposed person time. And of course, as we know in pharmacoepidemiology, whenever a drug is initiated or if it's stopped, there could be other things going on. There are reasons for that change in therapy that may be associated with the outcome. So you will have confounding by indication for the precipitant drug. So how do we usually deal with this? And this is where we bring in controls, and prior presentation kind of also talked about it. So for example, you have DDI exposed cases. You can run your screening exercise in DDI exposed cases, and then you also identify controls. In the best case scenario, your control will be a controlled object drug with the same therapeutic indication that doesn't cause DDIs. For example, if we're talking about simvastatin and we're concerned about CYP-mediated interactions, a control object drug could be pravastatin that doesn't have those DDIs, or metformin if you're talking about sulfonylureas. But in many situations, we don't have that control object drug with the same therapeutic indication, right? So what have been done in the past, so for example, Charlie and May have done it, you can still bring a negative control object drug that is known not to cause DDIs from a different therapeutic area. Like if you're looking at the bigger trend and your control object drug is pravastatin, we have also done controls where they're not exposed to any object drug or the object drug of interest. So it's object drug unexposed controls. And the idea is the same, no matter what control you're using, you're running screen exercise in the controls, and the adjustment is very straightforward. You divide your estimate in the DDI exposed cases by the estimate in controls. And the assumption, the main assumption, no matter what controls you're using, is that the magnitude of bias in controls approximates the magnitude of bias in cases. If it's not the case, you might end up with residual confounding, or you might end up with over-adjustment. So it's definitely something to keep in mind when you bring in controls. So are we done with the assumption? And unfortunately, it's not. So wherever design you use, and here I'm talking about self-control designs, there are also design-specific assumptions. So in self-control designs, in addition to the assumption that there is no time-varying confounding, there are also design-specific assumptions, such as in a case crossover. We have to ensure that the exposure probability for the precipitant drug is constant across the comparison windows. In the self-control case series, because you don't censor patients when they experience an outcome, you have to keep follow-up. There are two major assumptions: that the outcome does not affect drug exposure subsequent or before the outcome, and the outcome does not affect censoring, which in your case might adopt discontinuation of the object drug. Unfortunately, we know that sometimes it happens when an adverse event is a contraindication to subsequent therapy of the object drug. I don't have time to go into it, but we have done some simulation work and empirical investigations, and it looks like these assumptions really have to be violated to a large extent to have a major impact on bias. So if they're violated just a little bit, like for example, only like 30% of your patients discontinue object drug after an outcome, that might still not have such a big impact as compared to time-varying confounding. But these are definitely something to keep in mind when you're running self-control designs, either for screening or for DDI, kind of like hypothesis testing investigation. So let's go back to our common components of screening algorithms. So we have a study design, self-control designs. We bring in controls to address some additional bias. Now, you also will need to prioritize or rank your precipitants because you will be screening hundreds and hundreds of drugs. And also you have to keep in mind that what you're doing is multiple estimation. So the chance of false positives is going up, so you need to adjust for multiple testing. And there are different approaches out there, and what's usually done, either you can do an alpha-based approach, so you are ranking your drug based on the p-value, and you can adjust for multiple testing, and there are various methods to do that. You can bring in Bonferroni. We have done false discovery rate, which is less conservative. You can also do Bayesian approaches, and this is something that Charlie may have done and Sean. So you can use Bayesian shrinkage, either empirical, or you kind of like set up your prior, and then you rank your estimates after Bayesian shrinkage. But you'll have to do something to address the multiple estimation. And this is just an example. For example, we did a screening for statin and rhabdomyolysis, and you can see we have the estimates for DDI exposed individuals, for estimates for controls. We have the adjusted odds ratio, the nominal p-value, and then the FDRQ value, which is adjusting for multiple testing. So I guess I'm going to conclude with the DDI screening take-home points, and I thought I would remind people this actually doesn't only apply to screening exercises. Whenever you do any investigation, right, you get an estimate and you have to think through how you got this estimate, right? It could be true effect, it could be bias, and the bias could come from various sources, confounding, violation of design specific assumptions. There could be information bias, right? So exposure misclassification, and also could be due to chance. And in screening exercises, of course, we are working with multiple estimation, big data, so the chance of false positive can be quite high. But in screening, in addition to that, you also have to think about the absence of signals. If you adopt this paradigm that we're using screening as a first stage to identify kind of like hypotheses that we can take into more detailed oriented cohort studies, the lack of signals might mean false negatives, might mean that some DDIs are out there and we're not detecting them. So the absence of signals can again be due to bias, and all these sources can contribute to the bias and lead to the lack of signal, but you also have to worry about low statistical power and good clinical DDI management. So low statistical power becomes important because if you bring controls, and the controls, for example, are not some drugs that are not commonly used, that will reduce your power. And then of course, if it's a known DDI, so people will be less likely to be exposed to that drug-drug interaction, and you might not have enough patients to determine whether there is a clinical impact. Good clinical DDI management, I think people often forget about this when they run either screening or they do a study. Again, if it's a known DDI, you might end up with no signal because the DDI was managed well. It doesn't mean that there is no drug interaction. It means that in clinical practice, it is not a problem because of good management. And I think with this, I will conclude. I'm happy to answer any questions during the Q&A session, and I guess we will move to Sean next. Thank you.
Thank you, Kate. I want to remind people to go ahead and put questions in the question box. All right. So are people seeing the correct screen for me?
Yeah.
All right. Good. Let me just do one more thing. All right, good. So I'm going to be talking about how we can improve the impact of our DDI research. Here are my disclosures. So this first slide speaks to why we even do DDI research in the first place. So we know that older adults take many medications, with nearly 4% of older adults in the US taking 5 or more medications in any given month. Published estimates have reported that DDIs can cause up to 13% of adverse drug events and 5% of hospital admissions. The US Department of Health and Human Services National Action Plan for Adverse Drug Event Prevention, which Charlie referred to, focuses on 3 classes of high-risk drugs: anti-diabetes drugs, opioids, and anticoagulants, and calls specifically for research on drug-drug interactions. Research on DDIs takes many forms that can be arranged on a continuum from bench to bedside to population to public health measures. Pharmacoepidemiology studies are toward the right-hand side of this translational spectrum, just to the left of studies that evaluate the effects of efforts to reduce harmful DDIs. There are many compendia and computer knowledge bases of DDI information. The curators and editors of these compendia use different kinds of data and different assumptions in rating the evidence. Pharmacoepidemiology studies of potential drug-drug interactions are still relatively uncommon, so curators still must rely heavily on research further to the left on the translational spectrum. Unfortunately, as Anton pointed out, such research can be interpreted very differently by different people seeking to estimate the risk of harm. This is a different version of a slide that Anton showed, showing a truly astounding degree of disagreement among compendia. So this study examined agreement among 4 major DDI compendia, and as we can see, 72% of all the supposedly major pairs were listed as major in only one source, while 2% were listed as major by all 4 sources. Interestingly, there was actually a negative correlation coefficient between being listed in one source versus being listed in other sources, suggesting competition for scarce resources. So it's as if you had it in your compendium, made it less likely for it to show up in my compendium. This study concluded that drug-drug interaction alerts remain high despite over 15 years of efforts to improve DDI alerting systems. The authors concluded that we need to fundamentally question the premise of underlying drug interaction alert systems. One of the highest visibility papers examining drug-drug interactions was published in JAMA in 2003 by Yerlink et al. It found very strong associations between the presence of precipitant drugs given together with object drugs. This study also included negative control precipitants in a rigorous approach to address potential confounding by the precipitant. So these are some of the larger odds ratios I've seen in pharmacoepidemiology studies anywhere. But despite these rigorous methods, strong associations, and the high visibility of the resulting publication in JAMA, the paper by Yerlink, which was published in 2003, does not appear to have affected the frequency of the use of the object drugs together with the precipitant drugs, shown in red, compared with use of the object drugs together with the control precipitant drugs from the Yerlink paper, showed in blue. And here I have both the objects, the precipitants, and the control precipitants listed. So it seems like in the best case scenario, practice is not following research. In early efforts to improve the impact of our work, of the work of our group and others, we've produced a few videos and newsletters that are targeted specifically to the editors and curators of DDI compendia and knowledge bases. Many of the studies that our group has done have found no association and can hopefully lead to downgrading the clinical importance of many drug-drug pairs. While we're not overly optimistic that dissemination efforts such as these will have a large impact, we believe that not trying is simply not an option. We look forward to discussing these and other approaches to improving the impact of pharmacoepidemiology studies of DDIs. So with that, I'll thank you for your attention. We can take my slides down now, and we can start looking at the question box. So the first question, I'll direct to May first, but I'll see if others want to address that. And that has to do with sample size considerations. So, and Kate mentioned this explicitly. So it seems like one of the challenges of studies of drug-drug interactions is that you could take two relatively uncommonly used drugs and look for an effect on a relatively uncommon outcome. So are there ways to try to get around these limitations of available databases, particularly for infrequently co-prescribed drugs and or infrequent outcomes? Yeah, have any thoughts on that, May? We can't hear you, May.
Sorry, yeah. So as Kate pointed out, so what we have done in like the screening, DDI screening study is we do see there are drugs that are really infrequently used. But I guess, so one potential like rationale could be people are not using that frequently in a clinical practice. If that's the case, probably it's less as important to cause a problem of DDIs. But in our prior study, we did try to adjust for that to ensure certain estimates by applying apply a criteria for the minimum sample sizes to be available, and also to exclude some drug-drug interaction for some of the drug pairs that come up with a really unstable estimate. By that, we define as if something a model show up a signal with like a variance greater than 10, we excluded that from the analysis. And by using the sample sizes, we in the process, we use the cutoff point of 5 to define as a cutoff point for us to think like we would be able to get a stable estimate and get sufficient sample to detect the signal. Yeah, that has been the approach we have been used before. But anyone else has other thoughts on it?
Okay, Anton, would you like to address that?
Absolutely, and I agree actually with the initial point of being that if there are not that many concomitant users, it's probably not a place to start. Also, at times looking into other data sources. Warfarin is the classic example where you have the INR measures. You need close to nothing in terms of INR data to do a valid study. If you do the first INR after and the last INR before the new drug entered, you can do paired t-testing and you can obtain meaningful estimates with 10 patients or 15 patients or 20 patients. So if you can get actual data on plasma concentrations, which is for some of these drugs that are most relevant to study because they have a narrow therapeutic interval and therefore might be monitored, you can really do a lot. So those kind of data, plasma concentrations, are really, really important in this case.
Thanks. Kate, did you want to add anything?
Yeah, I think I just wanted to add that it's not only an issue in the screening exercises, right? So it's also in your cohort studies. And from my experience, like for example, when we did the clopidogrel and SSRI, I started with 500,000 clopidogrel initiators. So definitely, I mean, I think Anton just presented a very interesting case where he was fine to do with 10 or 20 patients. From my experience, if you're going into this sort of like DDI world, you have to have big databases because, you know, even if you have a lot of people using the object drug warfarin or clopidogrel, once you start looking new initiators, and then you have the precipitant drug, and then you need to have somebody who's a control, your big data suddenly becomes not that big anymore. It literally becomes a few thousands of patients. So yeah, for hypothesis generating exercises, like you probably need to do some power estimation before you go into that. For screening, one alternative, of course, is you have to then kind of like do the trade-off between false positives and false negatives, right? If you adjust for multiple testing, you reduce your power. You might not adjust for it and then just look at the top signals that will help you with power, but then of course it increases the chance of false positives.
All right, thanks. Charlie, did you want to add anything on the subject of the sample size?
Sure, just to build off of Kate's first point, which I think was a really excellent one, is that sometimes the most appropriate analysis, whether it be the least biased or least confounding, might be to limit your study to the subset of individuals that enter the cohort in a certain way. And what I mean by that is you might only truly be interested in studying people that were object triggered enterers. And right there, you're potentially cutting your huge sample size already in a third before you start implementing all the other things that you need to do. So as Kane pointed out, the critical aspect of having very large data sets, yet acknowledging the fact that they quickly become small. Thanks.
So I'm going to piggyback on something that you just said, Charlie, and ask you a question back. So both you and May mentioned the order of concomitancy: object triggered, precipitant triggered, and either combo or synchronous triggered. Do we always want to look at all three separately, or when do we want to focus on one versus the other?
Yeah, so I'll try to tackle that first. So I tend to treat, at least compartmentalize in my mind, the object and synchrony trigger together, because those are individuals that are newly initiating the object drug. And I think something as a pharmacoepidemiologist seems inherently strange about studying people that are precipitant triggered, because they aren't necessarily new users of the object drug of interest. And as was pointed out probably by a few people, is that we tend to study exaggerated adverse effects of object therapy. And so there tends to be some mixing of new users of the object with new initiators of the object, and something about that doesn't feel right as a pharmacoepidemiologist. So that said, in many of our prior studies, at least, we have looked for differences by methods of cohort entry, and haven't found very interpretable findings, is to put it mildly.
May, do you want to add anything to the question of when we might expect to see different associations depending on order of concomitancy, or your experience with that?
Yeah, I would like to add to, like Charlie pointed out, in terms of the if somebody like precipitant triggers, but I guess in certain scenarios, the example I presented earlier, like what we in the prior screening study, when we look at warfarin DDIs and the effect of that on the INR, it kind of like require the patients needs to be on warfarin, as we want to see require the patient to be stable on warfarin so we can see the dose change. However, I guess one of the approach could be limited. It's like could be kind of adjust that in terms of patients. We could start it the one we did is we started still with new user, identifying new users of warfarin first, and then just apply a kind of like a grace period to ensure patients are stable. So in that sense, the patients, although they are precipitant trigger, but still it's kind of like in that early phases of the object drug users. Yeah.
Kate, anything you want to add in terms of order of concomitancy?
I think the only thing I'd like to add is that I think pharmacologically, probably very few examples, like warfarin is an example, it might not matter which drug came first. The reason I usually split them is because I'm worrying about confounding. And the people who initiate object drug, they are in a completely different situation if they've been on the object drug for 3 months and then they initiate the precipitant. So I don't necessarily feel like it's good to combine this necessarily. You might be missing some confounding. So that's why the reason I'm splitting always when I do a cohort study.
Anything to add, Anton? Right.
No.
And of course,
Other than
I'm
that,
sorry, go ahead. Were you shaking your head no, but then you started talking. Go ahead.
I am trying to answer I will try to answer some of the questions that I'm thinking is less likely that we'll get to. There are a ton of questions and we're running out of time. So I'll try to answer some of the questions in writing. I hope I know what I'm doing, but so maybe questions will start being answered there.
Okay, great. A question for Kate, at least starting off with Kate, in terms of methods to deal with multiple estimation, frequentist versus Bayesian. So I know that you've so far used more frequentist approaches than Bayesian approaches. What are your thoughts about, what are the relative merits and limitations of both approaches?
Yeah, so I think you put it quite well. I think that both approaches actually have merits and limitations, and it's very similar to like case crossover versus self-controlled kind of like design question. So neither of them is perfect, and I think either is fine if you know what you're going into. So, you know, the Bayesian is great. A lot of people love it, but you do have to define a prior. And your stuff, and wherever you get just is dependent on a prior. What if you got it wrong? And, you know, like sometimes people do empirical prior. I'm not necessarily sure that empirical prior is the best way to go. The alpha-based approaches have their own limitations, and you know, it's the frequentist mode that a lot of people kind of question these days. Like, I'm not running like 100 trials, so to be honest, I feel like this is something again, adjusting for multiplicity. This is something that we probably should do in the screening exercise, which approach is used. And I think like some work has been done in biostatistics outside the DDI world that shows that there's not that much difference between the approaches. And of course, I'm sure you can find some examples when there is a difference, but on average, I don't think it matters much what you do as long as you do something and you know how to interpret the final results.
All right, thanks. Charlie, did you want to add anything to the question of Bayesian versus frequentist?
No, nothing to add other than to just re-echo that in the screening world, we should be doing something and in terms of testing or adjusting for multiplicity rather than nothing.
Right, okay, thanks. So I think I want to ask, go over one more methodologic point and then swing into dissemination. So somebody asked the question about whether we're looking at additive versus multiplicative interaction. I know, you know, some discussions with Anton. Are we even looking at interactions themselves? Sometimes do we start thinking that we're looking at an interaction, but then we look at a poorly recognized inherent effect of the precipitant drug? Do self-controlled designs limit us to multiplicative rather than additive effects? So there's a series of questions, and how about if we just go through each of you and you could choose to address one of those or something else. You want to start us off, Anton?
Absolutely. I love this question. I don't think additive interactions are interactions. They are by default not. I think if something is added on top of something and produces the same effect, increase in effect as it would have had the first drug not been there, it's not really an interaction. Is this an academic distinction? No. Consider two drugs. One gives you 3 points of drowsiness. The other one gives you 5 points of drowsiness on the internationally acclaimed drowsiness scale. If these are in fact interacting and combining the two gives 15 points of drowsiness, you need to know, because you cannot really give B to an A user because then the person falls asleep. If this is an additive effect, of course, people tend to become more drowsy by getting B on top of A, because 5 plus 3 gives 8, which is more than 3 or 5 individually. However, from a clinical point of view, I would look at a patient and just go, could you handle 5 more drowsiness points or not? And I don't need to consider whether you're already using A. I need to look at the patient, whether this is are you in this particular scenario, could you handle this? This is of course not the same thing in terms of, for instance, bleeding risk, but I cannot come up with a single example of something that is truly additive in, for instance, bleeding risk or other severe acute outcomes. So for the vast majority, this additive effect is in terms of risk of hypoglycemia, risk of sleepiness or being drowsy. And in this case, additive effects are clinically handled in a different way from multiplicative effects. So I don't think additive effects are important in this particular sense.
All right, thanks. May, any thoughts on additive versus multiplicative?
Yeah, so as you mentioned in our screening study, mostly we are studying on the multiplicative scale. I think in our prior screening study, when we were kind of like compare the multiplicative compare like the DDIs, compare like the incident rate when we include like a control group and compare the precipitant exposed versus the negative control, the object plus precipitant exposed versus a negative controlled object drug plus the precipitant exposed group. Sometimes on the multiplicity scale, although we don't see that effect in when we look at that so-called like ratio of the rate ratio. But if we look at the individual rate ratios on the additive scale, it seems for certain drugs there still could be an effect, but definitely there could be questions about how whether that's real or that's something like really clinical relevant. I agree that would need like more research into like more careful design study just specifically to studying that selective drug pair. But we do see for certain drugs like what we are expecting to see, for example, when we use like when people administer oral anticoagulants plus antiplatelets, where we expect the increased risk in bleeding, but on the multiplicity scale, we didn't see that effect. But when you compare the incidence individual rate ratios, it does seem to be there is like a difference on the additive scale. But yeah.
All right, thanks. Kate, anything to add on additive versus multiplicative?
So I actually have a very different approach to this as compared to Anton, I think. Well, first of all, when we talk about additive versus multiplicative, I think we're talking about scales. We're talking about our models that we run. If we are thinking about biological mechanism, I think that most interactions are probably additive. It's not like you add a drug and the risk increases by 2 or by 4 or by 6. So I think like I might be wrong, but I still believe that sort of like most interactions biologically work on the additive scale. The problem, of course, is that our models very often limit us to multiplicative, and the question becomes whether multiplicative models are good enough to kind of like detect drug-drug interactions. And in a cohort study, we can certainly estimate. We get some estimates. We can do absolute risks, and we can actually look into additive interaction to see maybe how it differs. In a screening exercise, if you're on a self-controlled study, then you're almost stuck because it's a multiplicative model. You don't know the absolute risk. You can only get the multiplicative. And when I do this work, I always think, again, the screening is just like this first exercise that I'm running, and then I will do the subsequent stage with the cohort design, and then we can investigate additive. But I think what really matters is actually the additivity and the additive. And by additive, I actually don't mean that not synergistic, right? So you can say, well, there is drug A plus drug B, and 2 plus 2 equals 4. Pharmacologically, it's an interaction. Epidemiologically, we don't consider this an interaction. 2 plus 2 must equal 5 for us to say there is an interaction. So synergy could also happen. And so additive is not just that the effect is the same if you put 2 drugs together.
So it's a departure from additivity versus a departure from multiplicity. Is that
multiplicity,
right?
Yeah.
Charlie, would you like to add anything?
No, nothing for me on this point.
Okay. Well, why don't we move over to how can we, or can we, and if so, how can we hope to affect real-world practice with our pharmacoepi studies? So, the results from Emily Acton's paper that found basically no effect of Eurolink's JAMA paper on the co-prescribing of those drugs didn't give a lot of reason for hope that our papers in clinical pharmacology journals are going to have much impact. Let me start with you, Anton. Any thoughts on how we can try to influence what goes on in the real world to improve practice from our research?
I think I'm sort of at the same place as you are. I am highly skeptical that whatever we currently can come up with will change the world, at least on a short-term basis. On the other hand, I don't think we really can allow ourselves to say we won't try. One example, I'm not saying this is the sort of the solution, but one example is that I'm currently doing a screening. We're doing 300 drugs compared to warfarin. I am, instead of publishing this as the second phase of the project, involving people running a DDI database and asking them as part of the project to evaluate our findings towards theirs and perhaps change theirs. So hopefully, if things work out the way I wanted to, we will have changed the database as part of the publication, thus having the publication show that you can change database with data. Hopefully, but that requires me to know the people running this database, or at least get in contact. I one late night considered maybe I should get sort of call up Micromedics and ask them to join the project as well, but someone said that's probably not happening, so I got away from that one again. But I think that's what we need to do. We need to befriend these people. We need to help them, and then we need to respect and address directly that a regulator running a DDI service, for instance, needs to consider to be loyal to SMPCs. If the SMPC says there's an interaction, a regulator has a hard time saying, well, the data is actually horrible. I don't think this should be included in our database, because they're sort of then sort of going against their own decision. So and then we have all sort of the law going on, the risk of lawsuits from ignoring this ideal data, etc., etc., etc. So I think before we can actually change the system, we need a discussion, very explicit discussion with those running DDI sources or software, asking, why are you doing this the way you're doing? Could we do a clinically relevant edition of this free from all the other distractions? This is a very long process, and we haven't even started yet.
Thank you. What was the abbreviation that you used? SM something? Never mind. Kate, do you have any thoughts on improving the impact of our work?
I really liked Anton's idea that you need to befriend people, because, like, for example, I know that in our hospital there's this information overload, right? So they're always complaining. The patient safety officers, they have those tons and tons of alerts coming up, and they don't know what to do with them. They would like to kind of, like, even on the hospital level, forget about like Micromedics or wherever, maybe to downgrade some of them and upgrade others. And I don't think they're necessarily using PharmacoEpi work to do this. I hope they do. So, but I think it, like, if they had us on a team that would work with them, that would be helpful. So I think, yeah, so maybe even if you start with your own hospital and you get on P&T committees, or you get on these patient safety committees, and you can kind of like promote PharmacoEpi work, that would be helpful.
All right, thanks. Charlie, anything that you'd like to add?
Yeah, just to state that getting an audience with the right individuals, in particular compendia editors, is just the first hurdle, right? The second is something you talked about, Sean, is they're so used to evaluating things so far to the left on that translational spectrum that they might not necessarily know what to do with a well done, or sometimes not as well done, pharmacoepidemiologic population-based study examining things. And part of it is what can we do to help them incorporate our type of work to potentially make changes to a database. And the example that I talked about in my talk of a sulfonylurea with gemfibrozil, Micromedics, as of yesterday, still had the interaction listed as moderate with good evidence in their database, despite the fact that the only reference they have is that case report. I sent them a message and just got a response back this morning saying that they evaluated my paper that I sent them, and they're planning on changing the text. So I see that as a little win. Is that an approach that's sustainable to do this for every single one moving forward? Of course it's not, but we need to start somewhere.
All right, thanks. I'd ask May for your response, but I think we're running out of time. This was a lot of fun, so I want to thank all of the presenters and Kate in particular for organizing this. I hope everybody goes ahead and joins ISPE's DDI SIG. And thanks for your attention, and enjoy the rest of your day.
Thank you, Sean. And I hope we have all these different answers recorded. I hope you can see the answers that I've put in. If someone is unhappy that I didn't get to answer that specific question, please send me an email and I'll have to include it. I think there's one very relevant ad to give now. a lot of people suggest that some of these discussions should be taken to the SIG. Yes, I think these discussions should be taken to the SIG. Please join the SIG. We'll continue all the fun in the SIG. Please join the SIG. Thank you.
Thanks for the plug, Anton. Take care.
Thank you, everyone. Have a great day.
Thank you.
Thank you. Bye.